Hi, hi. I'm Dr. Martin Rutherford. I am a chiropractor for since 1979, and more importantly to this presentation, as those of you watch know, I'm a certified functional medicine practitioner who's been practicing it for quite a while. This is my partner in crime here,
Dr. Randall Gates, board certified chiropractic neurologist, as well as being a chiropractor.
And the importance of understanding these two disciplines is that we have developed a chronic pain practice. Today we're going to talk about rheumatoid arthritis. Is the cause in the gut and or in the urinary tract? And the answer is maybe. Very strongly maybe, but over the years we've developed a chronic pain practice, and the significance of having the two of us together as Dr. Gates's discipline is really all about figuring out what's going on with the brain and the nervous system and how that can be contributing to chronic pain. The functional medicine discipline is figuring out all the other things that you read about in magazines, even more than that. You read about leaky gut, you read about small intestinal bacterial overgrowth, you read about all your vitamins and all your supplements. We got to do one on vitamins and supplements again.
In fact, our biggest fan, hi Becky, she requested that we do B12, which I think is a great topic.
Becky, we'll do B12. We need to do a lot more than that, frankly, based on a lot of my consultations lately. But the bottom line is, if we put these two things together, we put these two disciplines together, and there's really only three things that cause chronic pain: brain, the functional aspects of what's going on in the rest of the body, and what we have found is most often it's the immune system,
right,
and the musculoskeletal system, which kind of works out that both of us are chiropractors, and I've been one since 1979. So it gives us a good opportunity to evaluate a chronic pain syndrome in total, and then be able to address it because of the marriage of these two disciplines. We're talking about rheumatoid arthritis today. And it's not the biggest part of our practice. Dr. Gates was just saying, we got to me before, we have 3 going, I think, right now, and we get really good results with it. And we'll tell you what that means in a few minutes. But it's interesting. I think I might have just found out from Dr. Gates why it's not the biggest part of our practice, because it's not, I guess 1% is common, 1 out of 100.
It really is. It's pretty common for a health condition.
As peripheral neuropathy,
right?
Or
exactly.
Fibromyalgia, or thyroid problems,
right?
Or the ever-present gut problem here in this country, which I think is prominent in 99% of the people.
I was waiting for that statistic. I know,
but it's in a lot of people. It's in a lot of people. So these are the things that we see all the time. Now, a lot of those are going to contribute to pretty much every chronic pain syndrome that comes in here, even if it's dizziness or vertigo or something like that. So it's interesting to me that we see rheumatoid arthritis patients, they kind of drip in, but it's not like it's this overwhelming rush to what we do. And I'm wondering if they just don't think there's anything else that can be done for them, even though it's only 1%. So we're gonna, if you're watching this and you have rheumatoid arthritis, there are other things that can be done for you, and in the long run, frankly, are more effective, and in the long run are much less antagonistic to your immune system and the other systems in your body. So let's talk about rheumatoid arthritis. We already talked about, is it common?
Right. Relatively common.
1 in 100, I guess 1 in 100. Common's a very general term. So it's about 1 in 100 people.
Yeah.
1% of the population.
Typically, Parkinson's is 1 out of 100. Schizophrenia is 1 out of 100. Autism's now 1 out of 86. Some are now saying the high 60s. So it's a pretty common condition, amongst others. But what contrasts with rheumatoid arthritis is that, like, Parkinson's primarily affects those who are above the age of 60. So once you get above the age of 60, it can be 1 out of 10 have Parkinson's. So that's where we see these clusters of patients. Rheumatoid arthritis tends to be more the middle-aged female, not to be gender specific, but there's a female preponderance with this condition.
Right.
Yeah.
Right. I hardly ever see a male with it.
Yeah. I think we've seen 1 male in the last 5 years with RA.
So it's a very specific type of a condition in its presentation. And again, as chiropractors, I didn't get into functional medicine until I was in practice for quite a while. And I saw a lot of rheumatoid arthritis patients
Mhm.
back then, musculoskeletally, and the concept was, we'll mobilize what we can mobilize. Maybe that will stop the progression to some degree. We
Mhm.
understood that it was an autoimmune problem at that point. We understood there was nothing that could be done for it other than give people steroids. It's a whole different world right now. So let's first define it. Let's first kind of define. And for those of you who have rheumatoid arthritis, you're probably sitting there going, "Well, I know what rheumatoid arthritis is."
Right.
But we had one patient who came in here, tall, thin, slender lady. Obviously, I can't say her name or anything. And she had significant
Mhm.
rheumatoid arthritis, and her doctor said, "But your tests are normal."
Right.
And I don't mean to laugh, but I mean you'd have to be sitting there, and she has all of the findings we're going to talk about. And I said, "Well, okay, you have rheumatoid arthritis." She said, "Well, they don't know yet." This is how we have gotten to be so dependent on tests that we're like brain dead. If the test says something, it's like that's the way it's got to be. You need to understand testing is kind of a ballpark estimate in a lot of different types of cases. Some it's more accurate, some it's very accurate, and a lot it's not accurate at all. But that was kind of an interesting case where she actually said, "Well, I'm not sure," and her hands were almost, I won't say clawed, but they were pretty.
They
She
were
had a
very deformed.
She had a
yes.
challenge to use
Very
them.
deformed.
Okay. And so anyway, so clinical features of rheumatoid arthritis, and we'll talk about how you know whether you have it, in case there's someone else out there like that who's been told, well, your tests are normal, even though you're getting all of the findings of it. And Dr. Gates, we can discuss that because I think that's an interesting aspect of this, the RA factor.
Right. Oh yeah. We'll go into all that.
So clinical features of rheumatoid arthritis are,
in essence, your immune system is killing your joints. We have something called a synovium, which is basically a lining of the joints that is killed or attacked in rheumatoid arthritis. Also, tendons can be attacked by the immune system, as well as bursa. Bursa are fluid-filled sacs that basically are kind of like ball bearings for tendons to run over. In essence, that's a generality, but think of them that way. And so the immune system is basically attacking these areas of our anatomy. And there are selective joints that are involved with rheumatoid arthritis. Most commonly, it starts in the joints right here. These are called the metacarpophalangeal joints. They can also affect the middle knuckles, so to speak, known as the proximal interphalangeal joints, the wrists, the same joints in the feet as we're talking about in the hands, and then also the knees, most commonly. Rheumatoid arthritis less commonly involves things like the lower back, but it can commonly involve a little joint at the top of the neck, where your first and second vertebra in your neck are held together. And that's really important for any rheumatoid arthritis patient. We just had one the other day who was seeing her chiropractor, and I just kind of discussed with her, you really want to make sure that that joint is stable going forward, because I forget the statistics, but I believe it's somewhere in the neighborhood of about 60% of rheumatoid arthritis patients will get laxity at that joint at some point in their life. So that can lead to instability and possibly the spinal cord being affected. So that's really the clinical profile of RA from an anatomy standpoint and what's being affected. And then we can go into some of the other characteristics too that we have laid out.
Like the morning stiffness and stuff like that.
Exactly.
Okay, well, go into that. I mean,
well, and as you were commenting on, we're so dependent on the lab tests. We're so dependent on the x-ray. Really, rheumatoid arthritis is a clinical diagnosis. So it's not just that you have the lab features of it, you have to have the presentation and the history and the symptoms and the signs of the disorder.
And I want to go along with that just a minute. I had a patient in yesterday and had, it was a thyroid problem. And I'm gonna tell you right now, if you have an autoimmune thyroid problem, your thyroid numbers are kind of not usable until you start getting everything calmed down, until you get the immune system calmed down. And this gentleman was a perfect example of that. And I tried to explain that to him over and over again. And he just kept saying, yes, but my TSH is high, my TSH is low, and my T3 is low. And oh, by the way, his doctor told him that was normal. For those of you who don't know, that's not normal. That almost shouldn't even be able to happen. It means he's got an autoimmune problem. In a little bit of a way, rheumatoid arthritis patients seem to be confused. Their doctors seem to be confused would be a better way of putting it. Say, well, you may have it, you may not have it. So Dr. Gates's comment was, it's a clinical diagnosis. Here's what that means. it means you need to take a history. You need to know what rheumatoid arthritis is. You need to do an exam, and then you should be able to come up with a diagnosis with that to a certain degree, to a large degree, frankly.
Mhm.
And then maybe the X-rays are confirmatory.
Right.
But for the most part, you need to know. You need to be able to look at a person. You need to be able to do an exam. You need to be able to do the history, what Dr. Gates is just going to talk about. When I went to school, back in the early to mid 70s, back in the mid to late 70s, we didn't have these. We didn't have MRIs. We didn't have CAT scans. And we understood a lot of these tests didn't even exist. And we understood that the tests that existed were kind of shaky. There were even blood tests that they were kind of all over the place. So it was pounded into us to do clinical diagnoses, to do a good history and a good exam. And it's serving us well now because as most of you know out there who have these autoimmune problems, the lab findings out there are kind of unreliable, or they're inconsistent, or they're all over the place. One day they're positive, one day they're negative. So Doc, I think it's an important point for those of you who have rheumatoid arthritis. And the reason I'm going on this is because the rheumatoid arthritis patients that I see in the consults before Dr. Gates even, a good percentage of them are confused as to whether they have it or not based on the testing. So here's what you need to know about whether you have it or not.
So rheumatoid arthritis commonly starts with joint swelling, and you'll have tenderness in the joints that I mentioned before. Commonly it starts in the hands. It can be monoarticular, meaning like one little joint will be affected, but typically all the joints will be affected. And you'll see that they're swollen, you have a hard time moving them, especially morning stiffness. That is one of the cardinal features of rheumatoid arthritis, lasting about an hour. So you wake up and your hands are really stiff, not necessarily painful, but really stiff for that first hour. And then as your day goes on, they loosen up. That's one of the main clinical diagnostic entities that you have to be aware of. Now, going on from there, you can have joint swelling on all those other joints, the knees, the feet, the ankle. It may just present that way. We just had a case where a gal had a swollen ankle and she had rheumatoid arthritis. From there, usually doctors order lab testing. Now, the rheumatoid arthritis factor, which was commonly used for many decades and is still used in clinical practice, is a test that basically shows that everyone who has rheumatoid arthritis has a positive RA factor. There are a few percentage points there where there's a gap, but most patients with RA have a positive RA factor. However, just because you have a positive RA factor does not mean that you have rheumatoid arthritis, because a lot of other autoimmune conditions can be associated with a positive RA factor. There's a more specific antibody associated with rheumatoid arthritis called the CCP antibody. And the CCP antibody is really a specific immune cell that is more characteristic for how the immune system is killing the joints. It is actually one of the immune cells involved in that whole disease process. So that's why doctors are using that more commonly now. It has a higher sensitivity and specificity, meaning there are fewer false negatives and false positives with that test. And with all that being said, though, it's not perfect either. And so we have seen patients who have positive CCP antibodies who have no clinical characteristics of rheumatoid arthritis. Whereas
they have all the characteristics and are negative on their RA factor,
exactly,
negative on the CCP factor.
Right. And so that has to be taken with a grain of salt, just like everything else we're talking about. Now, then there's radiographic criteria for rheumatoid arthritis. Using the hands as an example, there will be joint swelling in the hand that you'll be able to see on an x-ray. You'll see that there's some loss of bone density around the joints because there's so much swelling, the bones actually start eroding away also in these regions. So that's the science, that's the medical diagnostic aspect to RA.
And did you go over the general system, like the malaise and the
I didn't. No, thank you. Yeah.
So then this is an important point.
It's really, how did I brush over that? So commonly patients not only have morning stiffness, but they'll be losing weight. They have fevers for no reason. They're really fatigued, those sorts of factors.
And why is that?
Because they have an autoimmune issue.
They have an autoimmune
Because basically their immune system is killing them, and that can be associated with weight loss.
So the thing I see in a lot of the discussions is, well, it's, my joints. What does that have to do with this? And if you have one autoimmune problem, it is highly unlikely for you to only have that one. It's highly unlikely that the immune system is not attacking other tissues in your system. But the immune system itself is really the problem.
Right.
I say this to thyroid patients. I say this to rheumatoid arthritis patients, and it's something to think about. Do you really have a problem in your joints, or do you have a problem with your immune system? And the answer really is you really have a problem with your immune system. And then a lot of these other symptoms are because of your immune system attacking other things.
Mm-hmm.
And we don't have to get into extensively, but the three other things that I see, I think you would agree, and if you don't, please correct me, is that thyroids tend to get attacked, guts tend to get attacked. Oh yeah, that's the name of it. And where are you going to get to the gut and the urinary tract?
Yeah.
And cerebellums, dizziness, vertigo, balance. Those seem to be the three secondary attacks, sometimes primary, that I see in the histories and the exams relative to somebody having a primary problem with rheumatoid arthritis,
Right,
or lupus, or whatever.
And to go a little further, basically a lot of what we're talking about here is coming from these new tests called Cyrix Array 5s, where basically we can categorize and see how many tissues in the body are being affected by the immune system. So they literally list 20 tissues in the body for antibody titers. And so what we're finding is a lot of our autoimmune patients are creating antibodies to several different tissues.
Right.
And though you may not have a diagnosis for an autoimmune cerebellar condition like gluten ataxia, your immune system still may be inflaming your cerebellum, causing maybe your balance to be a little bit off, or maybe your gut's getting affected and you just have some IBS-like symptoms. And so that's kind of the new frontier in autoimmune disease, in our opinion. Most rheumatologists that I've talked to are not aware of that.
But it's in the literature.
But it's in the literature,
like
absolutely.
A lot.
Absolutely. I mean, the coexistence, for example, between rheumatoid arthritis and Sjogren's syndrome is very, very high. And that's where the immune system kills the lacrimal glands, the submandibular glands, so you can't make tears, you can't make saliva. They tend to have a dry mouth and a dry eyes.
So you want to know if you just start getting red knuckles and red fingers, they start getting into, don't blow it off, especially if you have a gut or urinary tract problem.
Right.
Or especially just know that that's a sign that there are other things going on that you need to get checked. Now, I don't know who's going to check. I just thought I don't know who's going to check them, but maybe a functional medicine doctor. I don't know. In the functional neurology field, do a lot of people work with that type of thing?
I really don't know, because I think everybody does something different. Everybody has a different focus. We focus on the conditions that we've seen that we do really well with, and we don't take cases that we don't do well with. And so that's where we've gone in this direction of autoimmune disease relative to neurology and relative to generalized autoimmune disease and metabolic function. And yeah, that's our focus.
So anyway, just know there's more. Just know there's more. Just know if you have other symptoms, maybe they're all connected, and maybe you need to pull the string on that and follow up. Standard allopathic treatment for this is generally medications.
Those include, they used to use gold back in the day, but the methotrexate came along. Now people use sulfasalazine, they'll use Plaquenil, steroids in certain cases. Now the biologics have taken on great popularity. You see a lot of advertisements for these, Humira, Enbrel. These basically, all these medications calm down the immune system, but from different mechanisms of action. Just know methotrexate was originally designed as a chemotherapy medication. So it's just shutting down your immune system because your immune system is over-attacking you. And this is really the whole point of today's broadcast. When we were thinking about what we were going to do this week, I was looking at this and I was going to do all autoimmune disease and then realized that it was a little too broad relative to these underlying causes. So we're just going to hit rheumatoid arthritis today, but we're probably going to do one on Crohn's disease and ankylosing spondylitis.
But I think a general autoimmune presentation is warranted at this point in time, because people are starting to become aware of it. I'm seeing it in the consults all the time. People are becoming aware that there is this vast, and I am not using that term cavalierly, there is a vast, underappreciated autoimmune problem, and we can go on for a long time. I can go on for a long time as to all the things we think that have created it, because these are the things that we're treating or that we're assessing in the histories and so on and so forth. But probably a good thing to go over. The people who have rheumatoid arthritis, they're kind of in a different category. This is an autoimmune problem. They get it. They get it. People come in with subtle problems with their guts and their thyroids and stuff. It's a little bit harder for them to grasp that maybe they're getting an autoimmune problem. but nowhere near as much as it was just even 2 years ago. So I think it's a good subject. But let's get to the subject at hand now. We're kind of laying the groundwork here, so everybody's kind of on the same page as to rheumatoid arthritis and what it is and how it's being treated. But is the cause in the gut and the urinary tract? And anybody who has watched us knows if we know anything, or we think we know anything, we think we know about the gut, because we pretty much start with the intestines and the entire GI tract with every autoimmune patient that comes in here, which in our case is about 99% of our patients. And so it's an interesting area once you look back now at the fact that we're starting with the gut in everything. It's kind of like a duh. It's kind of like you eat food, the gut is kind of almost like you can almost consider it the outside of your body. You have this barrier that's trying to prevent anything that you're putting in there that doesn't belong in the rest of your body from getting there. And obviously it digests your food, the food's broken down, it's absorbed, and then it becomes your body. So to understand that maybe a lot of things could go wrong there that could be affecting other things. After you've been doing it for as long as we've been doing it now, we didn't start out with the gut, but eventually, maybe 4 or 5 years, we've been doing the gut. I don't know if we were doing it when you got here.
No.
We were doing that later.
Right.
We were doing that later on in our program.
The
then we started looking at each other going, when are we getting the biggest bang for our buck? And it was like, we talked about it. We almost said it unanimously. Yeah. We said, when we do the gut. And so we said, okay, let's do the gut first. So it's a big deal in all autoimmune cases. So but it has some specific nuances relative to rheumatoid arthritis. And Dr. Gates, our research maven here, and clinician, and our head clinician, treating clinician, is going to discuss those uniquenesses with you, because he utilizes the understanding of this data in the treatment of the gut. When I say gut, we're not just talking about small intestines and large intestines. We're talking about gallbladder, liver, pancreas, but mostly small intestines and large intestines. So,
and in this case, the mouth too, because that's where a lot of these microorganisms are being found too.
So let's talk about it.
Okay, perfect. Really the initial observation is we just started seeing these huge improvements in autoimmune diseases, Dr. Rutherford was saying, with addressing the gut. And so how can you possibly explain it? Is it food allergies? That's what we originally thought. We thought all of you autoimmune patients had food allergies, basically more technically termed food immune reactivity. So it's not an allergy like a peanut allergy, but your immune system was fighting the foods. And then we progressed on to leaky gut syndrome.
Some don't.
Right, yeah, and then we progressed on to leaky gut syndrome. So it was the foods leaking through the gastrointestinal barrier, immune system attacking the foods, causing immune inflammation.
And that's part of it.
That's part of it.
Not
and then
for everybody, but a lot of people.
Exactly. And then we progressed on to the microbiome, and so the effects of the microbiome on human disease, and then what the microbiome, these bacteria, what they produce. So
Some
they
people
produce.
might not know what a microbiome.
Okay, so the microbiome, I'm getting so used to everybody who's watching our videos and being up on it. So the microbiome
But all the
is,
new people who are
that's
watching
right,
may not know.
exactly. So the microbiome is the normal flora, the bacteria in your intestines, the bacteria in your mouth, the bacteria in your colon. There you go. And so when we get alterations of the normal flora, we call it dysbiosis. So dysbiosis is a term referring to when we get bad bacteria simply growing excessively in parts of our alimentary canal, which is the mouth, the small intestines, and the colon, and everything from your mouth to your anus, basically. So we progress to that, and then we progress to what byproducts these bacteria are producing. They produce what are termed short-chain fatty acids. And for example, some bacteria produce beta-hydroxybutyrate, which is really good for your immune system, and others produce other bad molecules that are bad for your immune system and your brain. And now we're to other features of this problem that we're talking about today, even your mouth being a feature of this. So let's go into Porphyromonas. Porphyromonas is a bacteria, the main one that they refer to as Porphyromonas gingivalis. And they started doing studies where they saw that rheumatoid arthritis patients had lots of immune cells directed at this mouth bacteria primarily. And they thought, well, that's kind of interesting. So is there a connection? And then they delved a little further and they found that the DNA of this bacteria was found in the joints of rheumatoid arthritis patients. Highly, highly, highly suspicious. And then they started taking this bacteria, injecting, and that was human studies. And then they started injecting it into rats and finding that when they inject this bacteria into rats, they develop signs of rheumatoid arthritis. So that has been our evolution with Porphyromonas gingivalis, and it goes a little deeper in that we find that this bacteria, we have to talk about molecular mimicry. That's a big component
This is a big issue
of what we're dealing with.
in autoimmune problems.
Exactly.
Of all different types of autoimmune problems, but yeah, it's big.
So think of a lock and key mechanism. So you have your key, you put in the lock, you unlock the door, you go in. Well, the immune system recognizes foreign invaders very similarly. And so if it looks like this, the immune system has a molecule called an antibody that looks like this, and it binds onto it. Well, we're finding that the Porphyromonas gingivalis bacteria and its DNA looks like the immune reaction that happens in rheumatoid arthritis. So basically, when you have DNA of that bacteria in your joints, your immune system starts attacking the joints, and it's very specific to that CCP antibody we mentioned earlier. And so it's basically a plus B plus C equals D type of scenario, if that makes sense, without getting too technical too quickly. Did that make sense?
To me.
Okay, and I hope it made sense to you. If it didn't make sense to you, email me.
Okay.
In essence, let's just go through it again. Basically, molecular mimicry, the Porphyromonas gingivalis causes little immune cells to attack it, and the immune reaction in that attack causes the RA, rheumatoid arthritis, reaction in the joints. And the CCP antibody is basically a byproduct of that reaction. That's what the current line of thinking is. And then in these studies, they found that Prevotella, which is another type of bacteria that's more commonly in the intestines and the colon, is also found in the joints of RA patients, and it also looks like this immune reaction. It causes this molecular mimicry to occur. And it's not as common as the Porphyromonas gingivalis in terms of how many particles of DNA are in there, but it is a piece of the puzzle. They've done other studies where they've seen that rheumatoid arthritis patients have this huge abundance of Prevotella species in their stool when they do anaerobic culturing, whereas normal subjects don't have that many Prevotella species, so that's another sign or line of evidence. One of the more interesting and new things that we've come across is Proteus mirabilis. Proteus mirabilis is a bacteria that's found in the urinary tract. And there's this gentleman out of England, I believe his name is Engelberger. He's attached to our reference list today. I may have slaughtered his name, so forgive me, Doc, if I did that. He's out of the UK, and he dedicated much of his career to looking at this one bacteria and its evolution of causing rheumatoid arthritis. And he's basically compiled every study on the planet and found that it's not just a problem in America, it's not just a problem in the United Kingdom. From 14 different countries, they have studies showing that this bacteria, very analogous to Porphyromonas, causes the specific immune reaction associated with rheumatoid arthritis. So we can have chronic infections in our body with certain types of bacteria, and the immune system may be trying to kill that bacteria in your urinary tract called Proteus mirabilis, and that is causing the specific disease process of rheumatoid arthritis. Because it attacks the joints. Yeah. And everybody is so focused, and he did a great article on genetics. So we're also focused on the human genome. And though there are some glimmers of hope now, we saw some of them when we went to our most recent conference in terms of how they're growing organs using genetics. But up until this point, the whole human genome product has produced minimal clinical tools for the average clinician to use on a daily basis. So we just don't have a lot of gene therapies, even though we are so focused on genetics. Right. And he has discovered that basically the genetics associated with rheumatoid arthritis are acutely involved in this molecular mimicry of these microorganisms attacking your immune system, attacking the microorganism, and therefore attacking the joints.
Yeah. So basically, I know I have celiac. Okay, so molecular mimicry has a lot to do with that.
That's a perfect example.
And serotonin.
Yeah, and because there
So basically, the way I explain to patients is you eat gluten, you eat wheat, you eat gluten. Okay, your immune system attacks it, and gluten has a very similar chemical or molecular structure as your thyroid.
Yeah.
Which is kind of weird, huh? Isn't that weird? So the next time you get the attack, next time you get the gluten attack, it attacks your gluten, and it looks for other things in your body that look similar to it. In this case, your thyroid and cerebellum.
Mm-hmm.
Yeah. And so that's molecular mimicry. It mimics the molecular structure of something else in your body, and now you get these attacks all over the place. I'm just doing that for someone who I thought maybe doesn't have
Right. That was a good
really,
example. Good analogy.
Maybe a background in any of the sciences, right?
Right. Because the gluten,
But that's what happens.
in this case, is just like the bacteria.
So it attacks the stuff in your urinary tract, and the joint tissue looks like the stuff in your urinary tract, your mouth, and your intestines. So it starts attacking that, and then after a while, it starts looking around for, maybe you get an overwhelming infection.
Mm-hmm.
Now it starts attacking that. Now you've made too many attacking antibodies, and now it starts attacking other stuff like your joints and your knees. And I have never seen rheumatoid arthritis in the back. And I'm shocked that you say that 60% of these things,
Mm-hmm.
because I cannot tell you how many years I've been adjusting with rheumatoid arthritis. I've never had a problem. But anyway, so
Yeah.
so see, every week I learn something new. So how do you do it? So what's the deal? So we have all these issues. How do we use this? First of all, how do you evaluate for it? Do you evaluate for it?
Mm-hmm.
And if you do or don't, what do we do with the findings relative to treatment?
Okay. And
there are tests, but
there are tests, good? And that's, a lot of these tests are used in research settings. Excuse me. The stool culture tests are not as good for us clinicians as they are in the research setting. So that's something we all struggle with. So that's where barrier integrity is really a big deal.
Yeah.
So
those of you who go to the alternative doctors, and in fact, I won't name any names, but you'll get your stool test, mm-hmm. and you'll send it off to one of the specialty labs, and they'll come back with a nice little graph, and it says how much Prevotella you have, or do you have it, or do you not have it, and so on and so on. We've used those. Okay, and they'll tell you whether they got parasites or whether they don't have parasites, and now mm-hmm. they don't even tell you that. So there's a lot of companies out there. I don't want to mention any of their names, because if I mention their names, you're going to think I'm saying they're bad companies. They're not. It's just that the tests just aren't there yet. Mm-hmm. But Dr. Gates is about to go with what we see all the time, and what we use all the time, and why we use it.
Mm-hmm. And so barrier integrity is huge. So if you have good barrier integrity, even if you have these microorganisms, they shouldn't be as much of an issue. Yeah. So leaky gut syndrome, we've talked ad nauseum about it. This newly acknowledged entity, it has a horrible name because of that, has a lot of skepticism within medicine, but now it has been really, it's unequivocally there for a lot of autoimmune conditions. Like type 1
gut does exist. It
does exist. Yeah.
It's not an argument anymore. It exists. It's significant.
And so the thought process is, how are these bacteria getting into your joints? How's the bacterial DNA? It's getting there because somehow it's permeating out of your mouth, meaning it's moving through the tissues in your mouth into your bloodstream, or it's moving out of the gut into your bloodstream. And then your immune system is attacking it. Or the urinary tract infection, or the immune cells to the bacteria in the urinary tract is then causing some of these issues. So assessing for leaky gut syndrome is something we can do. We use a Cyrex Array 2 on all of our cases to do this. We're in the process of writing an essay to other practitioners in terms of why every doctor practicing functional medicine, functional neurology, or the newly coined field of chiropractic rheumatology, as we're terming it, should be using a Cyrex Array 2, because until you know how solid the barrier is or how broken down the barrier is, you really can't assess your therapies. We know that these things, go ahead.
Okay.
We know that these bacteria are a piece of the puzzle for RA patients. We just don't know how severe the problem is.
Yeah, so what we're saying is, if you have rheumatoid arthritis, you got to get your gut checked, okay? Because there is a strong probability that what is driving your problem to get worse is coming from somewhere in this tract. Your gut is the most available to be checked for an entity called intestinal permeability, leaky gut, whatever you want to call it, that is probably contributing. And the reason we say probably is because this is data we're using to treat people. Mm-hmm. And our rheumatoid arthritis patients that we have had have done very well, and this has been a big part of it. And I think something for them to know, for the viewers to know, is if they don't have gut symptoms,
Right.
should they still get checked?
Absolutely.
Yeah.
Absolutely.
And we've blown that early on. You know,
Right.
we had people, we have this like 17-page history, the infamous now 17 pages. We have people come in from this, right? And usually people from far away, and they'll say, so yeah, you send me your 17-page history. But in the beginning, again, we're clinicians developing these protocols. And if somebody did a 17-page history and one whole half of it, of this one page is gut symptoms, if they didn't put any gut symptoms down, sometimes we wouldn't test for it. And then we found out the case wasn't going very well, and then went back, tested, and then found out they had everything. They had parasites, and they had H. pylori, and they had Prevotella, and they had just everything. So if you have rheumatoid arthritis, I'm thinking you're probably going to have to find a functional medicine doctor at this point. You really need to get your gut checked for leaky gut. Okay, for leaky gut. Not particularly, there's two separate entities. One's a stool test that you do to find out if you have Prevotella and all these different things. And we have seen those to be inconsistent. Okay, I'll be kind. And that's a fecal test. You need to go get a blood test, preferably Cyrex Lab 2, Cyrex 2 lab, and check for intestinal permeability. If you have it, getting that fixed could go a long way towards slowing down and or even reversing the immune attack on your system. Right. And again, remember, it's not just attacking your hands and your joints. There is a strong probability that there are other attacks going on that you may or may not be aware of yet. So it's really is an important point. So how do we handle it? We find out that they have leaky gut, and then should we tell these folks just to go to our leaky gut?
You can do that.
Or you want to talk about the diet?
Diet's huge. So leaky gut appears to happen due to a variety of circumstances. Some theorize antibiotics, others theorize that this dysbiosis that I mentioned earlier, bad bacteria growing in the intestines, creates a lot of inflammation. That inflammation can then break down the gastrointestinal barrier. Other people theorize stress. Needless to say, if someone has leaky gut and they're coming into our office, we first look at diet, because in essence, we want to remove every food intolerance you have, because that's removing every piece of inflammation that we possibly can. And then we look at feeding the good bacteria what they like to eat. So this brings us to our last point on vegetarian diets. So they've really done some cool studies that don't get out to the mainstream masses because they're not going to make $1 gazillion on it. But these studies looked at taking patients with rheumatoid arthritis, putting them on a 7 to 10 day fast. Then they went on to a gluten-free vegetarian diet. And they kept repeating the study. Finally, they just said, yeah, it is very effective for helping patients with rheumatoid arthritis. The thought process is that a vegetarian-based diet is really good for the good bacteria in your intestines. And if you feed the good guys what they like to eat, they have a greater probability of growing. And the bad guys don't like to eat those foods as much, so they don't grow as much. And so that can be pivotal in the disease process of an RA patient, just from the perspective of getting rid of the bad bacteria and then also healing up the leaky gut, because as you take away the inflammation, the intestines, which are just like skin, have a probability of coming back. We use natural antibiotics to kill off the bad guys just to speed up the process. We use healing agents for the gut that we found to be consistently effective clinically. And the other piece of the puzzle here is that if somebody goes through our process, and our diet is different from what I mentioned, but there are similarities. If you go through the process of getting the diet right, killing off the bad guys naturally, healing up the gut, and a person is still having symptoms, at that point, sometimes they need to be referred for a medical opinion on this. And there are doctors collaborating now in this field called integrative rheumatology, where sometimes medical antibiotics are used to kill off something like the Proteus mirabilis or the Porphyromonas gingivalis to get rid of those bacteria out of the system so that the immune system can calm down. And that's
but after you do that,
you got to go back in and heal the gut.
Gut,
right.
You have to go fix it. If
right.
you don't go fix it, then it's going to come back. A lot of these guys don't ever treat to see if it comes back, and the symptoms come back later. So, but yeah, in an integrated fashion, sometimes the medications are involved, and we don't use vegetarian diets with our patients. Now, if a vegetarian, my mentor, and I don't know, Dr. Karazian, if you're still doing this, because I never told you that I was a vegetarian, but he doesn't treat vegetarians, or at least wasn't at the time, simply because it just made it too difficult for people to get through the diet. Our diet, we haven't put a diet out. I don't think we're going to put a diet out. Everybody's putting a diet out. Everybody wants to have their name on something. Okay. Our diet is basically pretty much every allergen we've ever seen that has ever walked in this office has been taken out of the diet. And then we use that as a baseline to do an allergy elimination diet on the patient. And it's proven to be very effective, very accurate, way more effective than any of the other things that, any of the testing that's out there. It's my personal opinion. And again, I'm not cutting on these companies or anything. It may be because our patient population is primarily autoimmune, that those tests have proven to be inconsistent and unreliable for us. And so we went to the allergy elimination diet, and that has proven, and we even take out a few more things, but we allow our patients to eat meat, just simply but we're vegetarians. After you read about 500 studies that say, well, this causes this disease and this causes this bacteria to be better and this causes this to work. And the way you do it is eat broccoli, eat Brussels. It never says eat meat. Never. Look it up. Never, and we go to a seminar and what was it? The International Conference on
Human Nutrition and Functional Medicine.
On Human Nutrition and Functional Medicine. It's awesome. It's put up by Dr. Vasquez up in Portland, Oregon. It was awesome. Had like 19 presenters from all over the world. The doctor who did the paleo, all the research on the paleo diet was there. Just a bunch of luminaries there. It was really fun. And I had this big slide up there. And the slide was like 95% vegetables and fruits and all. And then they had almost like the obligatory little piece of meat in the corner, which was definitely like grain fed or so. Had no marbling in it whatsoever. And then a piece of fish. And then the rest of the slide was just fruits and vegetables and so on and so on. So the reality is, you can argue about whether we should be eating meat or whatever and go, we have teeth that mash and we have teeth that tear apart, whatever it is. The science shows that the vegetables are where it's at, the vegetables and the fruits. But I wanted to say one thing. What feeds the bad bacteria? And is not the bad bacteria fed by grains.
Grains and other foods that we're finding.
Yeah. So see, there's even nuances
Absolutely.
to the vegetarian diet.
Right.
Okay.
Because a lot of vegetarians become grainitarians, which is why I found it really interesting that this was a vegetarian gluten-free diet. And these studies were done before the advent of gluten-free products. So if
you go vegetarian, you're eating a lot of grains and your rheumatoid arthritis starts getting worse. Don't blame us. We just told you.
And we've tweaked our diet too with a few tough RA patients to more of a vegetarian base. And it actually worked pretty well. Right. But again, there are nuances because you have to evaluate, okay, potentially this food is going to cause this reaction, but this vegetarian aspect is going to help. And you have to say, what are the lesser of 10 evils? And so you substitute this food in because a lot of people can't just live on vegetables only.
Right. Which is why we're probably never going to publish a diet. Okay. Because, and I know there's one book out there, my wife just got it, and I haven't read it yet. It's called The Paleo Diet for Autoimmune Patients. And I imagine it's pretty good, in general. But the reality is if you have an autoimmune problem, man, your diet has to be tweaked to you. And I don't know how else to say that. And it's a lot of work, which is why it's not being done. And people want to write the paleo diet. No bagging on the paleo diet. It's a better diet than the American diet. People get on it, a lot feel better, and then a lot don't. And they're like confused. They come in here and go, but I'm already eating better than what I'm already on the paleo diet, or or whatever. Or
they're doing it 80% of the time and not realizing that the 20% or even 5% that you're off of it may be sabotaging all of your 95% of your efforts.
So the diet is huge. The nuances of diet are unbelievable. And so a lot of people don't take the time to do it. I understand that. We just made a commitment to do this. This is what we do. So we built our schedule around it. We built our testing around it. And it's a large part of people getting better. I would say it's probably 30, 40, 50% of people getting better. Healing their gut is a big part of getting better. we didn't really mention stress, but stress, if you are in a stress mode, and you'll know this by, if you can't fall asleep, your brain's going a million miles an hour, and then you wake up in the middle of the night, you can't go back to sleep, you're a little irritable, you just know if you're, this is more than stress, okay? This is something called like a little post-traumatic stress syndrome or a fight-flight mechanism. You can look up our module on stress. Is that how we titled it?
Yep.
You can look that up. And if you got that up, if you have that going along with this dietary thing, that's another big component again about getting better. And there are natural ways to deal with that other than Xanax and all the other things that they give out there. So I think that's a big component. And then, but staying better. For those of you who have that stress mechanism, that's certainly a part of staying better. You need to have strategies and mechanisms to help with that. However, if you don't, staying better is going to be like, diet is going to be like 98% or 95% of getting better. And maybe they end up with a few supplements on their gut. Maybe they don't. Maybe they end up with a vitamin D because they have autoimmune problems. But it's primarily, once you figure that diet out, man, that is your way to stay better. And staying better means what for a rheumatoid arthritis patient?
Having less flare-ups.
What is a reasonable expectation? I know what it is because I'm always talking to folks about that, but share with them what a reasonable expectation is for a rheumatoid arthritis patient.
I mean, our goal with each rheumatoid arthritis patient is to get them off their medications. Now that is with, yes, that is with the collaboration of the rheumatologist. Right. But frequently through these means, we have seen that patients can go to the rheumatologist, say, I don't need as much of this medication because they're feeling so much better. So we're stopping the progression. It's an autoimmune disease, so you're always going to have flare-ups, but to mitigate those flare-ups as much as possible.
So that those flare-ups are very minimal and very infrequent. And when I say stop the disease, and then I tell people and reverse it, I'm referring back to what we talked about earlier. We know, and I rarely share this with a patient that's sitting in front of me because I don't want to create some sort of an environment of fear. But we know that as rheumatoid arthritis stays around for a long time, other things start happening. Right. You talked about its close connection with lupus,
right?
And
Sjogren's.
Sjogren's, I'm sorry, and Sjogren's, and